introduction, my name is Tara and I'm from Croatia. I work at the Institute of Clinical Laboratory Diagnostic at Osijek University Hospital in Croatia. And today I will present delayed diagnosis of Addison disease in a child. Outline of my today talk will be case presentation, the role of clinical laboratory, and I will conclude with learning points. So 12-year-old boy was admitted to the Osijek University Hospital Center due to dehydration, nausea, and muscle weakness persisting for the last 2 months. His mother observed signs of exhaustion in him, as well as depression. And he had a general weakness. He was having vomiting, abdominal pain, and poor appetite, which result in weight loss. Upon admission at the hospital, he was hypertensive with blood pressure 90 to 45 and heart rate 97, and he was treated symptomatically without any improvement in clinical conditions. His laboratory findings indicated severe hyponatremia. Occasionally, the boy had elevated hyperkalemia, hypochloremia, prerenal azotemia, elevated liver enzyme, hyposmolarity and plasma, and endocrinological assessment revealed hypothyroidism with elevated TSH level and within reference interval FT4 and low FT3 level. Antithyroid peroxidase was negative, and cortisol as well as aldosterone were in the reference interval, but a little bit low. Adenocorticotropic hormone measured in his sample was significantly increased, and it was 429.5. All other laboratory tests which were performed to exclude systematic and organ-specific autoimmune diseases were without any observations. So more extensive laboratory findings were conducted to exclude or rule out the diagnosis for this boy. At start, analysis of very long-chain fatty acid was performed to rule out X-linked adrenal leukodystrophy, so it was excluded. Unfortunately, at that time, anti-adrenal antibodies like anti-21 hydroxylase antibodies were not able to perform in Croatia, so the presence of autoimmune adrenalitis could not be confirmed. Clinical condition of this boy was improved after replacement of glucocorticoid, obviating the need for further testing due to stabilization in his clinical condition. In differential diagnosis, it is important to at first mention that hypothalamus is producing corticotropin-releasing hormone, which affects the pituitary gland to produce adenocorticotropic hormone, which in adrenal gland triggers production of cortisol and aldosterone. Two diseases were considered in this boy, congenital adrenal hyperplasia, which consists of 70% of primary Addison disease in children, and the most common cause is deficit of enzyme 21 hydroxylase. In congenital adrenal hyperplasia, 17-hydroxyprogesterone is elevated, and this was not the case in this boy. However, severe hyponatremia with occasionally present hyperkalemia was present. Anti-adrenal bodies were not confirmed, and X-linked adrenal leukodystrophy was rule out. 70% of congenital adrenal hyperplasia is the cause of Addison disease, 15% is autoimmune adrenalitis, and other causes are tuberculosis, some drugs, tumors, and genetic defects. In steroidogenesis panel, if we move to the next slide, the most common deficit or is in enzyme 21 hydroxylase, which converts precursors to aldosterone and cortisols. Of course, there are some other deficits less common. After reimbursement of fluid in therapy and treatment, correction of hyponatremia was achieved, and the treatment with hydrocortisone, which is effective and inexpensive, was started, and that improved the boy clinical condition. The boy and his family was educated and informed that in case of severe acute disease with fever, it's necessary to enlarge hydrocortisone dosage, and it's very necessary to monitor glucose and electrolyte levels. So pathogenesis of Addison disease is unclear. Probably it's generated by a complex interplay between genetic, immune, and environmental factors. And the onset of symptoms most often is subtle, and the non-specific symptoms are developing gradually, like fatigue, nausea, vomiting, diarrhea, abdominal pain, weight loss, slow growth, and salt crowing. However, replacement of glucocorticoid is an effective way of treating this disease, and the monitoring of the condition is very important due to development of various different autoimmune disease, and more than 50% of patients will be diagnosed only after acute adrenal crisis, after infections or other kind of stress, and they will also have other autoimmune disease accompanied with severe hypoglycemia. Learning points after the conclusion will be that Addison disease and Addison crisis is a life-threatening disease, so proper and prompt communication in critical laboratory results from laboratory professionals without a delay to clinicians, in this case pediatricians, like hyponatremia and extremely elevated ACTH, are extremely important, and how measuring serum cortisol one should always have in mind whenever unexplained and severe hyponatremia is present, because lack of adrenal hormones may cause extreme sensitivity to insulin, causing hypoglycemia, which is particularly concerning in children population. So that's all from me today. Thank you for your attention.